Good afternoon to everybody. Thank you. Sorry not to be with you. I'm here in Cotignola, near Ravenna, central part of Italy. And on my right side, Dr. Mangieri, Dr. Sticchi, Alberto, and I'm not going to introduce everybody, but very nice people here. They've been very useful to do these live transmissions. So the first patient, and then we have another patient in the other room. Alessandro will present the history. I already have cannulated the vessels, but have done nothing except FFR and IUS.
Good morning to everyone. It's a great pleasure to be here and show this interesting case. We are going to present a patient of 83 years old, male, average age and weight. The patient was on acute coronary syndrome 1 week ago, and he was admitted to our department with a junctional rhythm and with an onset effort dyspnea from October, last October. So next, please. This is, you can see on the left, the clip of the right coronary artery during the ACS, and on the right side, the good result of the intervention.
Can you go back? They need to see the result on the right corner. Back, okay. Click. Okay, this is the baseline, cerebral stenosis, this is acute coronary syndrome. Click on, on the next. Okay, but I don't know why we cannot see. Anyway, there is a nice result on the right, you can imagine. Okay, they implanted 3 or 4 stents on the right. Next. And this is our target for today. This patient is part of a prospective study named FIRE trial, where patients are randomized between a complete revascularization versus FFR guided versus incomplete revascularization. This patient has been randomized to complete revascularization. So we see lesions on the left system, but before jumping on them, I think there is a clear cut lesion in the circumflex and a more questionable lesion on the LAD. Before doing anything, we need to do baseline FFR. The LAD is a kind of diffuse disease. The circumflex is more focal. So we have now a right radial approach, 7 French. We can use the 6, but we use 7 because we are using a Makoto IVUS, which is a little bit bigger. And we started with the LAD. We have a regular wire in the LED. Can you show the film that we did today? Faccio vedere I film di oggi. Go back, let's do from the very beginning. Dietro, dietro, dietro. Okay, dietro. Okay, so this is a baseline. You see the clear-cut lesion on the circ. We have to do FFR, but I think there's no doubt the circ is critical. And then there is undefined in this view of the LAD. Next. Here it's a little bit more, maybe in the mid of the LAD something. So this is a regular wire. We cross the lesion quite easily. Next. Then we advanced a pressure wire. This is the IVUS, but the pressure wire, there is a baseline PAPD of 84. Può far vedere se abbiamo memorizzato, otherwise I'll do live because we have the pressure wire there. The pressure wire now is proximal. Possono vedere I numeri là?
Yeah.
Okay, you see this is the baseline in the proximal part. I'm going to advance the pressure wire. Okay, here you see is 84 baseline. So you know when it's 84 baseline, you don't need adenosine, you don't need IFR, you don't need FFR. The diagnosis is there. But you can do RFR, faccio vedere RFR. RFR is 75, okay, so it's positive. Can you go back to PAPD? And we go a little bit more distal. And 84, 83, so nothing dramatic. So the baseline is that the bottom line is that where you see the jump. I come back, 83, 84, faccio vedere I numeri, ok, li vedono, 90. So the focal lesion is there. Let's show the IVUS. We did the IVUS with this Makoto. This Makoto is equipped with near-infrared, so you see the yellow. It will be nice to see the reconstruction with the yellow. Here we are in the distal LAD. The vessel is a little small trio. Not bad, some disease, nothing dramatic. Here's a little bit more disease. We are moving more proximally. Here the vessel is more healthy. And here there is some fibrosis, calcium. And here is, yeah, focal, very focal, severe fibrocalcific. So our plan is to do a dilatation and to do a focal stenting in that area. You see how beautiful is the pressure to guide you of what to do. Not long stents, not 40 millimeter. We don't use a stent to cure plaque. We use stent to treat stenosis. Okay.
Antonio, I have a question.
Yes.
Is there any an additional stenosis farther down? Do you think is significant in the LAD or no?
Yeah, in near the apex. I will go in the RAO and we'll see the distal stenosis. You know, considering the age of the patient, I'm maybe keen not to treat that very distal. He's 83 years old, and I think the more proximal. But we will evaluate the distal. I think it's a good point. So our stenosis now is in the mid of the radiopaque pressure wire. This is a trio non-compliant balloon, which we will use to predilate this lesion. Any other questions? I like to use this pressure to avoid long stents because it's okay, but I think if you can avoid to implant very long stent. So here we are, we said in the mid, we can inflate. Let's go to 10, 15. Balloon looks pretty well expanded. Okay. I like to keep it for 10, 15 seconds.
So what is the balloon size and also the size of the vessel at
trio
the
non-compliant is a trio vessel. Here maybe it's a little bit bigger than trio. Small 3.5 down. Okay, let's take a picture with the balloon there to see if we got the right lesion. Maybe a little bit more proximal. Okay, inflate there. 10, 15, 18, 20. Okay, the balloon looks well inflated, negative. And I like to work not on the pressure wire, on the other wire, because I can use the pressure wire to evaluate what we have done. Let me go more distal with the pressure wire. Let me come back with the first wire. Okay, faccia vedere sopra. Okay. Okay, we are more distal. So no much
much
improvement,
gain.
no
Okay.
much
Yeah.
improvement. Let's come out with the balloon, but let's leave the balloon there and take an angio and see why we don't have much improvement. Film. You know, angiographically looks better. Let's wait a little bit. This is a contrast FFR, which is 78, so clearly positive. Let me come back more with the pressure wire. Here we are proximal. So proximal is 87, so maybe we lost a little, no, 90.
Yeah.
So
around,
it's like before.
yeah, like around the diagonal,
Yeah.
there's some disease.
Let me re-advance.
Proximal to the diagonal.
Let's- Not so bad. 85, 86. Not so bad.
Why not do
So-
intravenous adenosine?
What do you think? You go for stenting or dilate more?
Angiographica looks quite well prepared, I think.
Yeah, and you know, by pressure, it's not perfect, but it's around 86, 85, sometimes touches 87. So I think, regarding POBA, we basically have a baseline gradient of 15, less than 15.
That is not bad.
So by the time of Grunzig, he will cut the gradient 20. So if the gradient was less than 20, was fine. But we moved 40 years more. But I think, now we are distal. With time, we have a gradient of 13, 87. So I think we are almost ready for stenting. Let's remove the balloon. The distal wire is a J. Can you remove? I keep the pressure wire there. I don't want to remove, but we have to remove the pressure wire anyway because I don't want to jade the pressure wire. We'll advance the pressure wire after stenting. So let me come back with the pressure wire. So I think we can proceed with stenting. We're going to use this new stent. Is an SMT Cruise 16 millimeter long trio. I think trio is fine. We can post-dilate with high pressure, but you could even go with the 3.5, but he's an elderly gentleman, 83. I think we have to be absolutely safe. We don't want to take any chance. And if we go with the 2.0, 3.0 balloon at 22 atmospheres, we will reach 3.2, 3.3. That will be enough So, as you know, I'm always more in favor of focal stenting to treat where the lesion is and not to treat diffuse disease unless you really need. ECG is fine, patient is stable. Okay, so this is a 60 micron stent. All sizes are 60 micron. The O0 is the other small thin strut stent, but when you go to 3.5 is more. So the length is really very appropriate. We try not to cover the diagonal, so we'll start a little bit distal to the diagonal. I know that Antonio wanted to treat also the plaque proximal, but we try not. But I have nothing against. If you do that, you may have to put a wire in the diagonal. Let's take a picture. Ready? I think we are in the point where we want to treat. Let's inflate. This balloon is as always semi-compliant. Let's go to 16, 18.
16, 18.
18. So this balloon at 18, it's already 3.2.
Yeah.
There's no question that every time you inflate this deploying balloon at high pressure, you take a little bit of a chance to create edge dissections, but I hope not.
But it looks nice, it's well expanded.
The balloon
I
is
think
well
it's,
expanded.
the lumen gain is excellent.
So 20 seconds at least. Okay, deflate. Creatinine is fine, so we can take pictures in a relatively liberal fashion. So the stent has been reasonably well deployed. Let's take a picture. The stented area looks fine. Of course, there is disease proximal,
Proximal to that, yes.
but let's see by pressure.
So angiographically, we will be very happy. So let's see what the pressure
What the
shows.
pressure shows, yes. Deja vu for define.
Yeah.
Okay, so we are more or less at the diagonal site.
Okay, let's wait. It's 0.83.
0.83, so it got a little bit worse compared to before, but maybe we have to wait a little bit. Let me go more distal. Here we are distal to the stent. So there is no gradient across the stent.
No.
Let me come more proximal. Here are more proximal to the diagonal. So here is definitely
0.9.
normal. Here is
Yeah.
almost normal. So there is some disease more proximal.
Proximal, yeah.
But let's wait a little bit because before was not so bad. Let me re-advance now. So here we are proximal to the stent.
Yeah, at 0.86. Would you try also with the nitrates? Maybe there's a small vasospasm induced by
Let's
the
give
guide.
some nitrates. So it's 86, 87. Tends to improve a little bit.
Okay, these are nitrates.
We can also, how much nitrates?
Size, one syringe is 300 milligrams.
Okay. Blood pressure is very fine.
Yeah, let's
Let
see.
me flash a little bit.
Okay.
We can also do an IVUS.
Okay.
Let's see where we are. So
Okay.
we are proximal to the stent. So 87, you know, is
It's improving, but not so.
it's improving, but what happened? Why did
87.
87.
Sometimes there's a disconnection.
So 87. Let's do an IVUS and see what's going on.
Okay. Let's flash.
So the stent looks pretty good.
The stent is good.
There is
There's
some disease. I leave the wire proximal. So the question is, should you have placed a longer stent? Should you place a stent now? Honestly, I'm more keen not to do anything because of the clinical setting.
Dr. Colombo,
Yes, sir.
isn't this what DEFINE PCI trial tells us? That we see lesions before and after the stent, which we think are not significant and leave alone. But if you do an FFR, you actually see that there is a drop in pressure across the lesion, and then, of course, what we don't know is whether we should be doing them.
Yes, I think it's also, I think it depends on many things. The amount of drop. If FFI is 81, 79, or if it's 65. Second, the location of the lesion. And 3, the clinical setting of the patient.
Yeah.
So here I am distal. I'm distal to the stent.
To the distal edge of the stent.
And let's start pull back.
Live.
No. We have to advance. Stop. We need to advance the catheter because the catheter was still in the guiding catheter. It's advancing a little bit slowly.
So in the meantime, Antonio, you said that this patient is in a trial. So does the trial mandate, let's say, a target final pressure measurement, or?
No, the trial does not demand FFR measurement at the end. The trial just demands FFR measurement at the beginning in order to decide if the lesion needs to be treated. So this business of measuring FFR at the end is something we are doing because we want to check. So now I have advanced the IVUS distal to the stent. Let's go live. Okay, so we are distal to the stent. Let's start the pullback. So distal, the vessel, here is the stent. Looks well expanded, maybe.
Still stent, here the disease, the diagonal is coming, and there is the narrow part.
There is a narrow part in the more proximal part. So maybe it's not a bad idea to place another stent. What do you think?
Yeah.
A short stent.
Yeah.
Proximally. We can place a 3.5 short stent proximal. That's what I would do.
So in this case, you will protect the diagonal, or?
Yes, I try to use the FFR wire test to protect the diagonal.
But before you told us that you don't like to jail this wire.
But I'm going to jail only in the distal part, not where the pressure sensor is. But this wire is not super, so I don't know if he's able to go. He goes into the diagonal. Okay. Small test. Okay, I think it's enough to give me. And
That's un altro introducer.
okay, mi dà uno stent 3.5, 12. No, 40. 3.5, 12.
Standard was don't jail them.
Martina, 3,5, 12.
3,5, 12.
Stent.
So let's take an angio and see where. Ready?
Okay.
So it's really, I mean, it's not so
They
bad.
are quite superimposed. It's not so easy to.
Yeah, but it has to be 2/3 proximally and 1/3 distal to the diagonal.
So the question is 12 long enough?
I think it's even if we leave a small gap between the two, it's not a problem because the vessel is healthy.
Yeah, and we have also seen at the IVUS that the tightest part is
It's
very focal, so maybe.
We just need to treat the lesion. And so I think over there the vessel is definitely 3.5.
Yeah. Can we make a measure just close to the tightest part?
Okay, so this is a 3.5. Then after we place the stent, we measure again the pressure, and then we go to Dr. Giannini in the other room. Hold the wire a little bit, pull back this wire. Okay. So this is the same cruise, 3.5. We did not pre-dilate, but I think it's okay. It's not some fibrotic, but we have to post-dilate most probably. Okay, so we said, let's take a film. Ready? I think I like there, inflator. Let's go to 10, 15, 18, 20. So a 20 is over 3.5.
Looks nice, I think.
Is well expanded. Okay, let's go down.
Yeah.
Let's use this balloon to give a little bit of a squeeze to the distal stent. Okay, inflate there.
Okay.
Go to 8, 10, not too much.
8,
10,
10.
down. Okay, 10, not too much. 8,
Okay. 10.
down. Okay, we did a little bit of a gentle squeeze to the distal stent. Okay, let's come back. Now, let's see if the diagonal is okay. If the diagonal is okay, we remove the FFR wire and we remeasure the thing. So proximally, vediamo le pressioni proximally. Why we see nothing there? You know, this FFR wire only lasts a little bit. I think it's kaput.
Because
It's kaput.
I think
I
that
think,
we are jailed with
yeah,
the proximal part of
when
the
we
transducer.
inflate the balloon, maybe we traumatize the pressure
Sure.
sensor.
Yeah.
Okay, let's take a picture.
Yeah.
Diagonal looks fine. I think we can remove the FFR wire. I don't know if you really want, I can give you another wire, but let's take a picture and we can do a run with IVUS and be happy with that. Okay, let's take a nice picture. I think looks fine.
Looks great.
It looks great, yeah.
I think looks great. I think looks great. So we have a 3.5 proximally. Let's see the distal, the very distal lesion. They go to RAO, obliqua destra. No, obliqua caudata, coda. So to see the distal, the mid LED, you need to go here.
Maybe if you can
Vediamo
pull
la
back,
punta,
if you can pull
la
back a little
punta.
bit the wire so we will
Yeah,
be
so we can see
seeing
that
better.
region, yes.
Okay,
Thank you.
ready? Yeah, there is a lesion there. I mean, I could treat that lesion. It's not a big deal. What do you think?
But honestly, I mean, as you said, is a older patient. You still have to treat the circumflex. If it's not required by the study, I'm not sure that they will treat it. What do you think? The other chairs.
So,
Can you microphone?
Yes, what do you
you have
suggest?
the FFR wire. Why don't you just check what is the...
Okay, I'm gonna have you go to Dr. Giannini. I'm gonna open a new FFR wire.
Un'altra guida da FFR.
check distal and check proximal what we have done, and I promise I'll get back to you after Giannini. Okay.
Perfect. Good work to you.
Okay.
So,
Okay. Thank you.
Antonio, you are back to your lab here.
Occhio al guida, guida il guida, prof.
Can you hear us, Antonio?
Okay, yes. So we measure we redid the FFR proximally after having placed the proximal stent at 3.5 and was 92, 93 proximally, 93 distal,
Yeah.
PDPA. So I think the 3.5 short stent was absolutely needed. And then we did the pressure gradient distally. Baseline was 86 and the RFR was 78, so clearly positive. So we stented the distal lesion. With the 2.5 stent, I wanted a 12, but they didn't have a 12. We had to place the 16, but it's okay. So now I delivered the stent not at high pressure, at 10 atmosphere because it's a smallish vessel. And we're gonna do a focal post-dilatation with a 2.5, 12 millimeter balloon. And the balloon is now there. I just wanna check the position, maybe advance the balloon a little bit more. Okay, small test. What do you think? It looks fine. Let's see if I can see the stent. No dye.
See the no dye.
I think we can go a little bit more distal.
Yeah.
Just a tad. Is okay,
Okay.
right there. Is where the branch comes off. We go to 10, 15,
15,
18,
18,
20.
20.
Looks well expanded. This is a 2.5 and negative. So we have this FFR from Abbott, which is okay. But to tell you the truth, my preferred FFR wire is the one from Boston. It's really so steerable.
I'm so glad to hear Antonio say that, you know.
Why?
Because you've got magic in your hands, and I thought every wire just flies when it is in Antonio's hands.
No, but I tell you, the Boston FFR wire, I love it. Okay, let me go down with this wire. This is the FFR. I moved it proximally because I don't want to traumatize. We are inside the stent, it's touching everywhere. You know, doesn't turn. Okay, so here we are distal to the proximal stents. Let's leave it down. So you see 90, 91, beautiful. This is
The goal that we wanted to achieve.
yeah, I think reimbursement after stenting should be 100% if it's over 90. And if you go down, you will
Maybe
be
200%, right?
20%.
So you get extra marks for doing a good job.
Yes, I think if you document with the insurance or with the patient that you got over 90, you get a little bit of extra reimbursement. That will really get optimal PCI. So now we are going distal to the just placed stent. Okay, it's a little bit more. Okay, I think it's fine. Let it down. 91, beautiful, beautiful.
So you still can be reimbursed also for this one.
I can be reimbursed. Okay, it's really, don't you think this is the way PCI should be done?
You'll be surprised, just a little bit before your case, we had a lengthy discussion on this and the results of defined PCI and how we should go with precision PCI in the future.
Yeah, this is, I tell you, if you do PCI like this, the gap between bypass surgery and PCI on revascularization will still be there, but we should be more narrow, will not be so wide. But, you know, it takes time. I think the only way to make it is to improve reimbursement. Okay,
Only the insurance
so
companies are going to
now
start
I have to
screaming.
go into the circumflex. So I'm going to go with the FFR wire into the circumflex. I have to check for criticality. I think that lesion is critical, no question. Huh?
Or that, yeah, the circumflex
These,
lesion is.
this FFR wire does not turn at all. US test.
And again, this is mandated by the study that you have
Yes.
to document.
Yeah, okay. Went down. Test.
So here your goal would be to go into the big marginal.
I think, or even, yeah, let's go in the big marginal. Makes more sense.
You want to change projection?
It's
Maybe
okay.
we need another
Yeah.
angle. I think there
Let's
is.
take a picture.
Yeah.
Floor.
He's gone past it anyway.
Let me show distance there. Maybe if it's positive there, it's fine enough. I can go with the other wire. Okay, let's see. You see, it's already 81 in that branch. You see? Baseline, 83. So if it's 83 in that small territory, has to be
Like 0 point.
significant in the
super
other territory.
significant
Yep.
Okay,
margin.
so here I don't know if you want to go with Dr. Giannini because this is a kind of vanilla type of situation. I'm
Yeah.
going to go with the other wire and
Yeah.
try to go in the real target. I'm going to
maybe-
predilate.
Yes, Antonio, maybe if Dr. Giannini is placing his stent, maybe if
Yeah, we
Yeah.
can see
would
that.
be interesting
And
to
the-
see the
and
placement of the
yeah,
ostium of the LED.
And honestly, I'm happy that the FFR went in the other branch because I'm going to use the other branch as a protection, and I'm going to go into the main branch with this one and stent over this branch. Let's go in the spider.
Origins and spread out.
Yeah, yeah.
Now he's.
It's earlier.
Yeah.
Back.
Let's take a picture in the spider. This one is a little bit beaten up, but it's okay. Take a picture. So, I mean, we could even use a very short stent and just don't go in the other branch. I'm going to stop in that kind of aneurysmal dilatation, and I'm going to go in the small branch with the wire, with the wire, but not with the stent. Okay.
Yep, true.
Okay, let's, should we predilate? Let's do an IVUS. We have IVUS, let's do it. Okay, let's do an IVUS. Let's do an IVUS. We have it. Let's see if we need to predilate. Every time you do something, you have to ask yourself why you're doing it. So, so we do the IVUS in order to check if we need to predilate.
Okay.
I like this approach. Not just do something for the sake of doing it. Okay. Okay, ready? Let's advance this wire a little bit. Okay. So this to me is a 2.5 vessel. So this other question we'll ask this IVUS is what is the size? Is it 3.0 or 2.5? The circumflex I would say, bring it closer. It's coming. Okay, we are very distant. Let me come back a little bit more because we don't want to stay here for longer. Okay, pull back. Where we are? No, it's not advanced.
It's not advanced.
Is
Stop.
it? Is the IVUS fully advanced? No, no, stop.
It's
How come we see there? We are so distant, it's so big. Let me just pull back. Okay. Okay, now it's pulling back. It's a huge vessel, this one.
1, 2,
It's a 1, 2, 3, 3.5.
1.5.
But where we are? Okay, that's where there is the aneurysm.
yeah, I think that this
It's
is
like
the
there is the aneurysm there. This is a 1, 2, 3 millimeter,
yeah, you see that we are coming back
and we
now.
are coming back. So it's definitely a 3 millimeter vessel, definitely 3 millimeter vessel, and there is almost an aneurysm there.
This is the left main,
Yeah. Okay.
and then we are.
So I think we learned a lot. We learned that is a. Let me re-advance. Let me re-advance. Stop. Let me do. Okay, live. I'm gonna do manual. Okay, I want to do manual. Manual advancement.
Okay. Here you are distal in the marginal.
We are distal in the marginal. Okay, I'm still in the marginal.
Yeah.
And the marginal is 1, 2, 3, 3.5. I'm now at the bifurcation, which is okay. I'm entering into the distal circumflex. And here is where the lesion is. Okay, this is the lesion. It's a little bit calcific. You see it shadowing.
Yeah.
But it's not so bad.
Yeah.
If you measure, here is the lesion. You see it very well with more than 180 calcium. And here is proximal to the lesion, which is a big vessel, definitely 3O.
Yeah.
And here is the proximal circumflex, with some plaque is 3.5. So, you know, if I know the trial, but that type of lesion with that lumen, calcific, I think should be left alone. But let's, we have to do the trial, we have to do it. But, you know. Okay, let's get un pallone. We have a 3O12 non-compliant balloon. If you want to go to Dr. Giannini, I'm gonna predilate because there is calcium with a 3O non-compliant, and then place a 3O 12 millimeter stent there.
And you will place it just before the aneurysm component?
Before the aneurysm, right at the end, right at the bifurcation. But I'm not going to go into the brain.
Okay.
1000 di Eparina.
Perfect. So if we can, in the meantime, good work, and in the meantime we go to the other room.
And maybe post-dilate with an 8 millimeter semi-compliant balloon at 3.5 to flare the stent a little bit proximally because I think proximally is really a big vessel.
Okay.
But
So can we go to the other room?
yes.
Okay, Dr.
Antonio, we are back
Colombo,
to you.
Okay, so we placed the stent 3O at the so-called bifurcation. And it's interesting that with the other FFR wire, just the pre-dilatation we performed with a non-compliant balloon gave an FFR, a baseline, and now you see that it's 96, 97. But there is a plaque in the... Non c'è il Cruz 225? Non ce l'abbiamo il Cruz 225?
Sì?
Sì.
We are
No, 20 is too long.
15.
Fai vedere, faccio vedere. We placed the stent where was, but there was some disease distally, and we inflated in the OM, and you see that there is a clear dissection.
Yeah, there's a dissection there.
It's not a benign dissection because it's extraluminal, which is fine, but in the mid, there is a little bit of low opacity. I'm not so happy to leave it. You could do a long balloon inflation. It could improve. But if we have, it's a small vessel, but maybe just for the sake of preventing occlusion, to place a very short 12 or 8, 225 stent would be better. So there are two options. Or you do a prolonged balloon inflation, 2.0 or 2.5 low pressure, or you place a short stent. We have a short
Antonio,
stent.
what is the etiology in your opinion of this dissection in the OM?
Oh, I inflated the balloon there.
Okay.
I went distal with the stent balloon. It's a iatrogenic dissection. I inflated,
Okay, we can see that.
I inflated the balloon. 225.8, 225.8, 225.8.
Too small.
I inflated with a balloon there.
I think Prof maybe it's a little bit larger, the diameter. Maybe 2.25 is
You think it's too small?
Yeah,
Yeah,
because you see
225
that
is
the-
too small,
Okay,
Antonio.
too small,
You'd done an
too
IVUS
small.
here.
Don't open. 2.5. Give me 2.5. 2.5.
I thought
2.5.
on I was that OM.
2.5.
because we
was
did
a
the
Even
I5.
if you don't have 8, give me 12.
Antonio, you remember your IVUS findings.
Yes,
It was a
you're right.
big-sized OM.
You're
The
right.
OM is
Should
not
we use
small.
The 3O? Should we use the 3O?
Yeah, 3O is appropriate.
Fine.
Yeah, okay.
Yeah, 3-0. 3-0. 3-0. You are absolutely
3.0
right.
16. 16.
3016. You are absolutely right. You know, that's the value of light transmission, to have
Some
the
suggestions.
panelists that suggest.
See?
But Antonio would have corrected me.
Yeah. But
He already. I think the key of a good intervention is to listen to other people. Not always, but sometimes.
otherwise,
It depends who you
things
have
can
around,
be worse.
Antonio.
But I think it's very important in life to be willing to listen and to change your opinions. Very important. But the IBUS was really the key. I mean, can you believe it? Go from 225 to 3.0.
2.3 is, yeah, it's something different.
Is this a supraflex or cruise?
So this is Cruz.
Mm.
Even
So
Cruz.
we'll see if it goes through the other stent.
They claim a good pushability, so we
They
will
claim
see.
a good pushability. Let's test. This is a real good test.
Also because there's a double curve, so it's okay.
But there was disease at the beginning.
Yeah,
We did
yeah.
not notice in the areole. Phew, my God. Look at that. It went there. I don't know. Take a picture.
Okay.
Okay. I think it's fine.
Yeah. Let's see maybe also in the other projection, because maybe we
Okay.
are in another
After
2020. Okay. Excellent.
Okay, let's take a picture here also. There is a clear dissection. No bueno, eh?
Yeah. Maybe we
Okay.
can overlap a little bit proximal, just not
I
to
think
cover.
it's okay. Like
Okay.
this. Okay, go. It's not a small vessel. Can you believe 225? You're crazy. I think 225. Sorry, but sometimes, you know,
You work too hard, Antonio.
That's
No, Prof, it's okay.
But at least the chairs deserve the dinner tonight. So.
Yes, absolutely, absolutely.
Okay.
I listened to the lecture of Dr. San Giorgi. Very interesting, I must tell you. Very interesting.
Okay, I'm at 13 atmosphere.
Maybe you got
13,
distracted
no
by that.
negative.
Okay.
And I'm going to come back a little bit with the balloon. Okay, due test. Okay, inflate. Go to 14, 16, 18.
18.
We're going to destroy this pressure wire.
He's kind of worried.
18, 20.
Okay, 20.
Okay, so it's like a post dilatation. Look at that. Down. Let's do
Okay.
also here. Go to 20. We don't need to post dilate this.
Okay, 20.
Down. Okay. Pressure wire is
We have
still
still
okay.
some signals from the pressure
Yeah,
wire.
it's still okay.
Yeah.
Still okay.
Now the
92.
value is 0.90.
Okay, picture.
Okay. I
That's
think
very
this is
nice.
Perfect.
really nice.
That's very nice. Now you see some proximal disease, but it's biased due to double wire. Let's see, vediamo.
Okay.
Let me see if I can go. I think it's fine. We're
It's
gonna.
perfect, yes.
I'm not going to even measure the P
No, no,
pressure
no.
distal. It's fine. It's enough. Abbastanza for today. Let's take a spider.
Okay. Bit
Okay.
back the wire, Prof.
I think it's fine.
Yes, great.
I think it's fine. In 5 years, this patient, we're going to do an angio follow-up. 5
Okay.
years. Okay. Tutto bene, abbiamo finito. A posto. Okay, I think it's nice. I think 2 lessons. IBUS to tell you the size, pressure wire to evaluate the result, and other people to listen to suggestions.
Perfect. So
Okay.
thanks a million, Antonio. Great case.
Thank you very much.
And,
Bye-bye.
Congratulations also to your co-workers. So now
Yes.
we are going back to Dr. Giannini
and then
in
we
the other
show-
lab.
Perfetto.